Hello everybody, Dr. Ryan here. Hope you and your family are well. I am excited today because we're talking about some shocking topics. This is our first video regarding data interpretation and we're going to be delving into ECGs. So fasten your seatbelt. This is just, a rehash or a revision of how to approach an ECG. So whether you be a medical student, an internship doctor, whether you're doing your registrarship or residency in internal medicine, or whether you're a seasoned physician, this is a nice rehash of how to approach an ECG. Let's go! A big thank you to emottawa.blog, which is where I derived this handy chart. So guys, the important thing is that you got to be systematic. If you're not systematic, you're going to be missing things, all right? So first up, you're going to check the age, gender, and name, and check the paper speed. It should be running by convention at 25 millimeters per second, and the voltage should be running at 10 millimeters per millivolt. Then you want to check the rate. So if your rate is regular, all you got to do is count the number of small squares between the R waves, so that's called the RR interval, and take 300 and divide it by this number to get your rate. But if the rate's irregular, all you're going to do is count the number of QRS complexes on the rhythm strip right at the bottom and multiply that. So you count it over 10 seconds and multiply that by 6 to get your rate, right? Then in terms of rhythm, sinus rhythm is defined by having a P wave preceding every QRS complex, and the P wave is going to be positive in leads 1 and 2. Right? A normal rate is between 60 to 100 beats per minute. Anything below 60 beats per minute is classified as bradycardia. Anything above 100 beats per minute, tachycardia. All right. So then we look at axis. All right. So for axis, you're going to look at leads 1 and 2, or you can even look at 1 and 3 or 1 and AVF. Right? So if lead 1 is positive and lead 2 is positive, that's a normal axis. But if 1 is positive and 2 is negative, that's left axis deviation, and the causes of that are inferior myocardial infarct, Wolff-Parkinson-White, left ventricular hypertrophy, left bundle branch block, and left anterior fascicular block, right? That's what we said. But if 1 is negative and 2 is positive, my friends, that is right axis deviation, and the causes are listed here: anterolateral MI, Wolff-Parkinson-White, right ventricular hypertrophy, right bundle branch block, dextrocardia. All right, then we look at your intervals, all right? Looking at our PR interval here, and normal PR interval duration is 3 to 5 small boxes, which is essentially 120 to 200 milliseconds, right? So if you have prolongation of the PR interval, we speak to the phenomenon of atrioventricular block, and we'll be looking at a couple of examples, right? And if you have a shortened PR interval, that implies there's some accessory pathway between the sinus and the AV nodes, and examples is Wolff-Parkinson-White and ectopic atrial pacemaker. Looking at the QRS duration, the normal duration is 2.5 to 3 small blocks, which is equivalent of 100 to 120 milliseconds. It's wide in the context of a right bundle or a left bundle branch block, all right, or even if there's a paced rhythm, okay? Then looking at your QTC, which is the QT interval, which we have to correct, right? So normal corrected QTC interval in females is anything below 440 milliseconds, and in males anything below 420 milliseconds, right? Classic causes of a short QT interval is hypercalcemia, and that the whole truckload of causes for a long QT, where we think about the antis and the hypos. Think about antibiotics, antipsychotics, antidepressants, especially in the setting of TCA overdoses, antihistamine, antiarrhythmics, hypokalemia, hypomagnesemia, etc. Right? Then for hypertrophy, we look at atrial hypertrophy and ventricular hypertrophy. So with atrial hypertrophy, if the P wave is above 2.5 small boxes, or if the P wave is biphasic, we call it P mitrale, and that speaks to left atrial enlargement. But if your P wave is above 2.5 small boxes tall, and it's not really biphasic, then we call it P pulmonale, all right, which implies right atrial enlargement. To determine whether there's left ventricular hypertrophy present, we use a Sokolov-Lyon index, right? So you take, it's a sum of the R wave in V5 and the S wave in V1, and if that generally is above 30 millimeters, then you know you are dealing with left ventricular hypertrophy. And if you have T wave inversion with that, that's what we call left ventricular hypertrophy with strain. Very common in the setting of long-standing hypertension. For right ventricular hypertrophy, guys, we speak to the lead V1 and look at the R wave. The R wave is greater in amplitude than the S wave, or is greater than 7 millimeters, right? Together with right axis deviation. And the differential for that is pulmonary hypertension, mitral stenosis, pulmonic stenosis, right? So in the setting of ST elevation MI, this is the evolution of how the QRS looks in the ST segment. So before infarction, we have a normal trace, okay? Then minutes to hours just after the infarct, we may have ST elevation. We may even have hyperacute T waves, right? Then hours to days preceding this, you can still see the ST elevation, but we have Q waves beginning to form and we have T wave inversion. About a week thereafter, the T wave inversion becomes slightly less, but the Q wave persists. Months afterwards, the T wave inversion has resolved. We've got a normal T wave, but the Q wave persists for life. Alrighty. Then regarding ischemia, guys, so we know we're going to do our biomarkers, so our troponins, our CKMB, and we do the ECG and echo findings. So we said pathological Q wave is going to be 1/3 the height of the QRS in 2 leads or 1 small box wide and can indicate a new or old infarct. Then ST elevation MI means that you got J point elevation more than 0.1 millivolts in any 2 contiguous leads, right? Except V2 through V4 in V2 to V3 in men, and according to these criteria, right? So we know that there are different territories of different vessels. Okay, so the inferior territory are leads 2, 3 in AVF, and that's taken by the coronary artery, the right coronary artery. But watch out, because the right coronary also supplies the sinus node, so inferior MIs can complicate with bradycardia. And you do want to do your right-sided leads, your V4R, in the setting of an inferior MI, or else you're going to miss a right ventricular infarct. And we know that right ventricular infarcts are preload dependent. So please hold your nitrate, please hold your morphine, and give your IV fluids. Okay, V1 and V2, this territory is the septal territory, is taken by the proximal left anterior descending artery. V3 and V4 is the anterior territory taken by the distal LAD. And then you got your far lateral territory, which is 1 AVL, V5, V6, taken by the circumflex artery, right? Then you got the posterior as well, right? Alrighty, and then we got a whole truckload of STEMI equivalents. So guys, my approach here is that I'm going to be showing you the ECG, and then my suggestion is that you pause the video and then you take a few moments to analyze it according to our schemata, right? So what do we see here? Our schemata is rate, rhythm, axis, intervals, hypertrophy, and ischemia. So what can we see here, my friends? Well, the rate, so you're going to take the number of small blocks between the RR interval, right? So that's 300 divided by 5 will give a rate of 60, which is normal. All right. Then the rhythm, you can see a P wave preceding every QRS. All right. And that is a normal rhythm. Axis, we look at 1 and 2 and look at the predominant deflection of the QRS, and that we find is a normal axis. Right. So your PR interval, we said, is between 3 to 5 small blocks. And if we count it here, 1, 2, 3, 4, 5. So this is a normal PR interval. All right. And then in terms of your QRS complex, that's below 3 small blocks, so that's normal. All right, and your QT interval is also normal in this particular example. Is there any hypertrophy? So we look at the circular ion index. So it's the S wave in V1 plus R wave in V6. So if you count it 5, 10, 15, 20, 25, nope, there's no hypertrophy. And is there any P pulmonale or P mitrale? Nope. Is there any ischemia? These ST segments look pretty damn good to me, and there's no T wave inversion or ST depression or Q waves. This, my friends, is a normal ECG trace. Well done, well done, and well done. Alrighty, what do we see here? So once again, I suggest that you pause the video and give yourself a few moments to analyze this trace. So once again, according to our schemata, rate, rhythm, axis, intervals, hypertrophy, and ischemia. What do you notice, my friends? Can you really see any P waves? Nope. And is this a regular rhythm? Indeed, it is not. We can see the differing intervals between the RR waves. This is definitely atrial fibrillation. So we find that the P waves are absent, the rhythm is irregularly irregular, in that the RR interval is irregular, and there are fibrillary waves. Causes of atrial fibrillation, my friends, most commonly in clinical practice is according to this mnemonic match. Mitral stenosis, alcohol, and when atrial fibrillation happens in the setting of alcohol, we call that the holiday heart syndrome, which is an example of a paroxysmal atrial fibrillation. Must always search for thyrotoxicosis, so it's prudent to do your thyroid function. Also happens in the setting of coronary artery disease and hypertension. Alrighty, what's happening here? Well, the main abnormalities we can see is ST elevation in the inferior territory, 2, 3, AVF, 2, 3, AVF. We also have ST depression with inverted T waves in the lateral territory, 1 AVL, and in lead V2. So this, my friends, is an acute inferior ST elevation MI. And this one, pray tell, two important abnormal findings here is we have ST elevation in V1, V2, and V3, and pathological Q wave. So this patient queued out in V1 and V2. So this reflects an acute anteroseptal ST elevation MI. In terms of our immediate management plan, so if the patient comes in with an acute MI within 12 hours with onset of the chest pain, you want to consider thrombolysis. So you've got to rule out any contraindications to thrombolysis, and you can thrombolize with streptokinase or tenecteplase or alteplase. Alrighty. And then our management for such patients is you want to give them a stat dose of aspirin and a stat dose of clopidogrel, which is what we call the dual antiplatelets. All right, give them oxygen if the saturation is below 95%. Other antiplatelets we can give is prasugrel and ticagrelor, but locally these are not really available. All right, and you also want to give a stat dose of a statin, high dose, 80 milligrams of atorvastatin is where we go, and you want to cover the patient with enoxaparin sodium, which is Clexane, at a dose of 1 milligram per kg PD, and we give this for 5 days. Alrighty. If the blood pressure permits, later on we can add a beta blocker or enalapril, which serves the anti-remodeling process and diminishes myocardial oxygen demand. What are the complications of myocardial infarct? We stratify them into early and late. So early, there's a whole truckload, right? Arrhythmias in the way of ventricular ectopics, which is most common. You can also get ventricular fibrillation, ventricular tachycardia, sinus bradycardia. We said complicates inferior MI specifically because you're knocking off your sinus node. Sinus tachycardia, atrial fibrillation, heart block, the list goes on. Cardiogenic shock, cardiac failure, and we can split this into diastolic and systolic, left-sided, right-sided. Acute pericarditis, which is often common on the second or the third day. Thromboembolism, which can be systemic or pulmonary. You can have mitral regurgitation if you rupture those poor pap muscles or chordae tendineae. Ventricular septal defect, if you rupture your ventricular septum. If you rupture your ventricular free wall, you end up with cardiac tamponade. Not too good. Late complications include ventricular aneurysm, the dreaded Dressler syndrome, and post-infarct angina, which is not very uncommon. It happens in up to 50% of patients. Okay, what's happening here? What's happening here? Here we can see Q waves, right? Pathological Q waves in leads V1, V2, V3, and T wave inversion in the lateral territory, V4, V5, V6, right? Yeah, and you can see some degree of ST elevation here as well in the anteroseptal territory. This is an old anterior myocardial infarct. Okay, once again, don't forget to pause the video to give yourself a chance to interpret this before we get into the answer. So here we have pathological Q waves in the inferior territory. 2, 3 AVF, this is an old inferior myocardial infarct. Oh, what's happening here? Quite nice, no? So here we have a wide QRS in all the leads, but we have a RSR pattern in 1 AVL, V5, and V6. So we look at this QRS, it's wide. Look at this, it's wide. It's more than 3 small blocks. And we have the so-called William configuration, where this almost looks like a W in V1, and the QRS looks like a M in V6. William speaks to left bundle branch block. Right, what are the causes of left bundle branch block? So it happens in the setting of severe coronary artery disease, acute myocardial infarct, cardiomyopathy, and aortic valve disease, be it stenosis or regurgitation. So what's happening here? That QRS looks wide and juicy to me. Wide QRS in all these. We have RSR pattern in V1, V2, V3. If you look at the QRS in V1, it looks like a M, and it looks like a W in V6. This is right bundle branch block, and the common causes we see, it could be a normal variant, it could be an acute MI, it could be atrial septal defect, it could be cardiomyopathy. Don't forget pulmonary embolus. What is happening here, peeps? So we note that according to the circular Lyon index, if we're going to add the S wave in V1 plus the R wave in V6, and if it's greater than 30 millimeters, that's left ventricular hypertrophy. So indeed that is the case in this ECG. 5 common causes of left ventricular hypertrophy in clinical practice: systemic hypertension, aortic stenosis, coarctation of that aorta, hypertrophic obstructive cardiomyopathy, ventricular septal defect. What's happening here? Well, here, according to the circular line index, we end up with left ventricular hypertrophy again, S wave in V1 plus the R wave in V6. But we also have T wave inversion in one AVL V4 to V6. What is happening here? This is what we call left ventricular hypertrophy with a strain pattern. That poor left ventricle is just so thick that it's getting strained. And the common causes are hypertensive cardiomyopathy, hook'em, and subendocardial MI. What's happening here, peeps? So here we can see the tall R wave. The R wave shouldn't be tall in V1, right? A criteria for a tall R wave in V1 is over 7 millimeters, and this is 10, so that's definitely quite large. As well as we have ST depression and T wave inversion in V1 and V2. So this is what we call right ventricular hypertrophy with a strain pattern, and causes in our clinical setting commonly chronic cough pulmonale, mitral stenosis with pulmonary hypertension, primary pulmonary hypertension. So there's something happening that's causing strain on the right side of the heart, commonly coming from the pulmonary circulation, pulmonary stenosis, Eisenmenger, and etiology of fallow. What's happening here? So the P wave here is wide in leads 2 and 3. It's wide, right? And it's notched in lead 2. So this speaks to P matrale. P wave in V1 is biphasic. Look at that. With a prominent deep negative deflection and a small initial positive deflection. This is P matrale, and the most common cause, mitral stenosis as well as mitral regurg. What is the abnormality here? Here we see the P wave is nice and tall in leads 1, 2, and 3. This is P pulmonale, which speaks to right atrial hypertrophy or enlargement, and common causes of P pulmonale, chronic obstructive pulmonary disease with chronic cough pulmonale, which is by and large the commonest cause. Other somewhat less common causes, atrial septal defect, tricuspid regurgitation or stenosis, pulmonic stenosis, pulmonary hypertension from any cause. And we know, according to the WHO classification, that can be pulmonary arterial hypertension, venous hypertension, can be on the back of hypoxemia, thromboembolic disease, or there's a miscellaneous group. Mention what's wrong here, guys. So remember to pause the video if you want to give yourself a chance to interpret this. So here, look, there's ST elevation everywhere. And this is not just normal ST elevation. It's not your garden variety ST elevation. This is upward concavity in your ST elevation, so-called saddle shape, in 2 AVF, V2 through V6. This is acute pericarditis. Listen for that pericardial friction drop, please. 5 common causes we have in our setting following acute MI, but usually on the second or third day. Infective etiologies, we split that into viral, bacterial, fungal, protozoal, but by and large in our setting, TB pericarditis, common. Coxsackie-B echovirus, common. Less common fungal and bacterial. Okay, and then we have staph Haemophilus. What about acute rheumatic fever? Can give it to you. Acute renal failure on the back of severe uremia. Malignancy. Carcinoma of the bronchus, breast, lymphoma, leukemia. Collagen vascular disease, don't forget, always suspected as a young female of childbearing age with other stigmata of autoimmune disease, especially SLE and scleroderma. Okay. So, when thinking about etiologies of common medical conditions, this is just an aside, right? This is my approach. So if that condition, ask yourself, can it be congenital or hereditary? Is it infectious? And when it's infectious, it can be divided into viral, bacterial, fungal, protozoal. Is it inflammatory in the way of an autoimmune problem? Is it infiltrative? And the different infiltrative conditions we have is cryoglobulinemia, hemochromatosis, amyloidosis, porphyria, and sarcoidosis, chaps. And is it iatrogenic in terms of something that we as physicians have caused through our drugs or through our procedures? Is it a toxin, especially to get a history of herbal intoxication, over-the-counter medication? Is it traumatic in nature? Is it endocrine? With endocrine, we split it into the different endocrine organs. So is it pituitary, which is anterior or posterior? Is it thyroid? Is it parathyroid? Is it pancreas? Is it adrenal? Is it one of the 6 organs, right? Is it neoplastic in the way of a primary neoplasm? It could be a secondary or metastatic lesion, or could be part of a paraneoplastic syndrome. Is it metabolic in the way of organ failure or electrolyte or vitamin issues? And is it degenerative? That was just an aside, guys. Here we can see a beautiful, gorgeous pacing spike, followed by a QRS complex. And by you note that the QRS complex is wide, it almost looks like a left bundle. What's happening here, guys? Well, the heart rhythm is high. This is sinus tachycardia. The heart rate is 110 beats per minute. It's a normal rhythm. The P, QRS, and the T waves are all normal. Sinus tachycardia, guys, scariest rhythm in the hospital. Sinus tachycardia, scariest rhythm in the hospital. Why? Because there's always an underlying cause. There's always a reason why somebody's heart is racing. And it's our job as physicians to figure out what, when, and why. Okay, important causes of sinus tachy can be physiological in the way of someone who's just anxious, or someone who's exercising. They could be in pain, they could be showing emotion, they could be pregnant. All of those are physiological responses. Pathological responses include anemia, fever, thyrotoxicosis, shock, with one exception of vasovagal attack, because that will cause bradycardia, and heart failure. Alrighty, what's happening here? Looking a bit bratty there. Heart rate here, if we take 300 divided by the number of small waves, it's going to be 50 beats per minute, which we know by definition is bradycardia. The rhythm is regular. There's a P wave, QRS, and T waves, which are normal, and this is sinus bradycardia. Common causes, it can be physiological, especially with athletes and during sleep, because during sleep, your vagal tone increases, and that causes bradycardia. It could be hypothyroidism, hypothermia, raised intracranial pressure, can give you something we call Cushing's response, where you get bradycardia, hypertension, and altered mentation. And the reason you get the bradycardia is because of an inhibitory effect of raised ICP, or intracranial pressure, on sympathetic outflow. Drugs, and more drugs can cause bradycardia. Jameson, right, beta blocker, verapamil, right, basically blockade the level of the atrial ventricular node. What's happening here, everybody? So the heart rate here is 140 beats per minute. The rhythm is regular. P waves are absent. Can you see those P waves? Hey, P waves, where you at? Can't see you, man. The QRS is narrow, and this is a supraventricular tachycardia. Important causes in our setting could be physiological. Some people have a lot of Red Bull and energy drinks, which can bring this on. Anxiety, tea, coffee, alcohol, thyrotoxicosis, ischemic heart disease, Wolff-Parkinson bind, and digitalis toxicity. Alrighty. How do you treat a supraventricular tachycardia? Rest and reassurance first up. Then we try our maneuvers. A carotid sinus massage, not bilaterally, right, simultaneously, please, because then you're going to evoke syncope, right? So carotid sinus massage on one side, or a Valsalva, that serves the purpose of increasing your vagal tone. You can give adenosine at a dose of 6 milligrams IV, rapid flush, and then you raise the arm, right? If that doesn't work, you can repeat adenosine at 12 milligrams and then 12 milligrams again. If it's refractory SVT, opt for a beta blocker or digoxin. But remember, all of this applies just if the patient is hemodynamically unstable. Hemodynamically stable. In a hemodynamically unstable patient, you want to go the route of synchronized DC cardioversion. What's the abnormality here? Okay, that PR interval is longer than 5 small blocks. So this has to be atrioventricular block. Okay, and this is going to be first degree because it's just a long PR interval. We're not dropping any beats. All right. So this is a fun representation of first degree heart block from MedComic.com. We find that the PR interval is more than 0.2 seconds, and the QRS is asking the T wave, "Are you sure you ordered the pizza?" The T wave said, "It's like this every time." Right? Mamma mia, we late again. The PR remains consistently lengthened from cycle to cycle. And the 4 common causes of first degree AV block: dish toxicity, and more dish toxicity. Could be in the setting of an acute MI, commonly inferior, because we said that knocks off the sinus node. Acute rheumatic carditis, and hyperkalemia. Okay, what's happening here? The PR interval, guys, is getting progressively longer and longer and longer, and then you have a drop beat, right? The RR interval is also irregular in that you have progressive shortening of the RR until the block occurs, okay? This is second degree AV block, otherwise more affectionately termed Morbus type 1 or the Venkerbach phenomenon. Did you know Venkerbach was a DJ? Why? Because he dropped the beat. Thank you to MedComic.com for this. So you get progressive prolongation of the PR interval, and then suddenly you have a drop beat, right? What's happening here? We have drop beat here, but note that the PR interval is constant. It's a constant thing. There's no progressive lengthening, right? And in this particular instance, this represents what we call 2:1 AV block, right? So it's Mobus type 2 second degree AB block with 2:1 conduction. And this is demonstrated in this diagram that there may be a fixed relationship between the P waves and the QRS complexes. Alrighty. This is more dangerous than second degree type 1 because this easily becomes complete heart block. What's happening here? Okay, if we here, guys, we can see that the P and the QRS waves are just not talking to each other. They got bad blood between them. So the PP interval here is constant. The atrial rate is 60 beats per minute if you count the interval between the P waves. And the ventricular rate is 35 beats per minute. So there's no relationship between the P waves and the QRS complexes. They're just not talking to each other. This is complete or third degree heart block. And patients who have third degree who don't get paced are in danger of death. We come deeper there. What's happening here? This is just an example of two premature ventricular beats. And the characteristics of these ectopic beats is that P waves are absent, the QRS is wide, which is over 3 small blocks. The T wave is opposite to the major deflection, as we can see. And these are definitely ectopic or ventricular premature beats. And common causes in our setting can be a normal variant in young adults because of anxiety, excess caffeine, alcohol. Could occur in the setting of acute myocardial infarct, cardiomyopathy, due to electrolyte imbalance, and then we have hypokalemia, dish toxicity, and mitral valve prolapse. Okay, this is a scary rhythm. The QRS is bizarre, wide, and irregular, and this is ventricular fibrillation. How are we going to manage this, or rather, what are the different causes? Happens with acute myocardial infarct due to electrolyte imbalance, and then we have hypokalemia or hypomagnesemia, electrocution, drowning, and drug overdose, especially DIG and adrenaline. How do you manage that? Immediate defibrillation. Don't waste time. Call everybody in the ward. Say you got a resus. Get your emergency trolley, get out your paddles, and you want to do immediate defibrillation. Start up at 200 joules and 200 joules, then progress to 360, and that is in a defibrillator machine, right? And it can be biphasic, right, or monophasic. If 3 shocks are unsuccessful, you want to opt for adrenaline and then CPR, right? Important findings here, that T wave is very tall, man. Tall, peaked and tinted, and the P wave is wide and small, and this speaks to hyperkalemia, right? Also, other changes can be the PR interval is prolonged, and the QRS may become wide, slurred, and bizarre. So high potassium intake can cause it, and hyperkalemia often happens in the setting of renal failure. It can be acute or chronic, or in the setting of impaired tubular secretion of potassium. Endocrine disease like Addison's, it can happen in diabetic ketoacidosis because remember that insulin is going to help shift your potassium into these cells. If you can have insulin deficiency or increased insulin resistance, that potassium hangs outside the cells in the blood. Cons as well, because remember that the main role of aldosterone is to increase or upregulate the epithelial sodium channel in the kidney, right? And what that does is it brings in sodium and dumps potassium, right? If you have too much of aldo, right, you can end up with a situation of hyperkalemia. Right, and drugs like potassium-sparing drugs and ACE inhibition. Sorry, let's go back to this. In Addison's, you're going to have hyperkalemia because you're not going to have enough aldosterone. So your potassium is going to hang outside in the bloodstream. How do you manage hyperkalemia? So we got to withdraw any potassium-containing food and drugs. You do a potassium shift, right, with 20 moles, 50% dextrose, 10 units acrapid, and 10 moles, 10% calcium gluconate. The calcium gluconate is going to stabilize your cardiac membranes. Your acrapid is going to shift that potassium into the cells, and your dextrose prevents the poor patient from becoming uroglycopenic. The next step, if this fails, is correct the acidosis with sodium bicarb. You can give beta-2 agonist, you can give Kexlate, which is a potassium-binding resin. If all the above fail, hemodialysis, people. So these are basically a simple way to represent changes in the ECG in situations of hypo and hyperkalemia respectively, taken from live in the fast lane. Thank you so much, guys. So in hypokalemia, you end up with, it's like somebody literally pushing the ECG downwards. So you have T wave inversion with ST depression, and you may have a prominent U wave. Hyperkalemia happens like somebody is literally pulling the ECG up. So you have peaked T waves, we have P wave flattening, you have PR prolongation, and a widened QRS complex. Okay, I just want to encourage you from scripture as always. Today we're speaking about faithfulness. In the book of Luke chapter 16 verse 10 says, "He who is faithful with little will also be faithful with much." Indeed, God has given us all talents and abilities to use for His glory and His kingdom. If you are faithful with whatever you have, but even if you have resources in the way of money or time or your ability, sow it into the kingdom, and you will see how you will reap the reward. I mean, what a man sows is what he will surely reap. If you are faithful with little, you will also be faithful with much. God bless you. Here are my references. I'll see you soon with another helpful video on this channel. God bless.